Good afternoon, everyone. Center of Excellence, School of Tropical Medicine, Kolkata welcomes all the participants for today's RDLS session. Today's topic is integration of NCD screening and management among PLHIV at the ART centers. And the speaker today is Dr. Dolanchampa Modak ma'am. Dr. Dolanchampa Modak ma'am is the Assistant Professor of Tropical Medicine and the Deputy Program Director of the Center of Excellence in HIV care at STM Kolkata. She is also a master trainer for NACO and a faculty of PG Diploma in HIV Medicine course for IGNO. She has several publications in national and international journals. We welcome you, ma'am, for today's session and request you to start the session. Requesting participants to kindly bear with us. Ma'am will join us in a minute. Kiran sir, can you please stop the recording till then?
Okay, good afternoon, everybody. This session is about the non-communicable diseases among the HIV infected people. So in this fourth decade of HIV, we all know that with the advent of antiretroviral therapy, the lifespan and the quality of life is gradually improving. Now, much more number of people, much more children and adults are living a healthier life compared to previous decades now. And they are now, like the other elderly population or the general population, they are also suffering from various non-communicable diseases as comparable to the previous decades. These non-communicable diseases are hypertension, diabetes mellitus, coronary artery disease, stroke, cancer, bronchial asthma, and all other like these. And the death due to the adverse event of diseases, these diseases are much more commoner in this decade compared to the previous one. So it is very important to screen and assess the patients for NCD, and integration of NCD care with the NACP program is very much needed nowadays, as the people are living longer and the people wants a good quality of life than before. Implementation of integration of NCD care to the PLHIV at ART center, and we will discuss how we will proceed further. So with the widespread access to antiretroviral therapy, now HIV is transformed from a life-threatening condition to a manageable chronic condition, and the demographic is changing. So significant proportion of patients are living for more than 50 years, as I have already mentioned. And like the general population, they are also facing the challenges due to aging. So suffering from non-communicable diseases. I have already mentioned that few of them are more common compared to the other. Among the cardiovascular system, hypertension is the commonest one, followed by ischemic heart disease, stroke, and myocardial infarction, and rheumatic heart disease, though it is less common, but it is still present. Among the respiratory problem, asthma and COPD are occupying the majority of the list, and followed by cystic fibrosis is though remain undiagnosed. It is there, and few patients also develop pulmonary hypertension. But among the endocrinology department, the more and more patients are developing their diabetes mellitus, not developing, but they are diagnosed as of having type 2 or type 1 diabetic mellitus, may be diagnosed in the pre-diabetes or gestational diabetes 1. CKD is now a emerging topic among the HIV infected people. Some develop CKD as the primary disease. Primary pathology may be hypertension, maybe diabetes mellitus, but HIV is also responsible for the development of CKD. And the other thing, the tenofovir, the most of the patients are now getting tenofovir. It is also a criminal drug for develop the CKD. Among the central nervous system and obviously the psychiatric system, depression is quite common among this population. Anxiety, schizophrenia, though remain undiagnosed, they are very much common and they need much more attention. Blood anemia is very prominent in India, and it is much more common among the HIV infected population. And in the like the east coast areas of India, West Bengal has a large number of patients suffering from hemoglobinopathies, though they are present in various parts of India, so they also need much more attention. Number of cancerous diseases are increasing in this decade. The people are more suffering from the cervical cancer, lung cancer, oral cancer. Another common cancer is colonic cancer, stomach cancer, prostatic cancer. So as the people are much living longer, they are suffering from this type of non-communicable diseases much higher compared to the previous one. And also musculoskeletal diseases, they are also coming more and drawing more attention among this population. The overall prevalence of diabetes is around 11.4%. The pre-diabetic incidence is around 15.3%. The prevalence of hypertension was around 35.5%. Prevalence of generalized obesity is quite common, higher at the higher range. 28.6% patient develop obesity, and abdominal obesity, that is 39.5%, is much more higher. And those are associated with the obesity, dyslipidemia, hypertension, diabetes. They are much more associated with sudden death, and due to myocardial infarction, CVA, and all these. These are all well established facts. All metabolic disorders in non-communicable diseases except prediabetes are much more frequent in urban compared to the rural population. The important cardiovascular disease are coronary heart disease, central nervous system, cerebrovascular disease, peripheral artery disease, rheumatic heart disease, and deep vein thrombosis and pulmonary embolism. These are much more common compared to the other diseases. So there are several factors which are responsible for the increasing number of cardiovascular diseases in India. We are going through the coronary vascular disease epidemic. And there are some factors which are involved in the biological risk, and population level risk factors are also there. Biologically, Asian, particularly Indians, develop cardiovascular diseases much earlier in life compared to the European population. And there are some inherent biological and genetic factors which are also responsible for the development of cardiovascular diseases, especially in the earlier life compared to the Western population. And the epidemiological transformation or shift is there is epidemiological shift from non-communicable disease to non-communicable diseases in India. There is more involvement of NCD among the urban population, either due to environmental factor, there are socio-cultural factor, nutritional factor, and economic factors, all influences for the development of NCD among this general population and also HIV population. So risk factors for the cardiovascular disease, commonest one is hypertension. Sometimes it is unnoticeable, and that's why it is recommended to measure the blood pressure at ART center level at every visit. Diabetes mellitus, second one, it is very much common also, followed by dyslipidemia. And to identify dyslipidemia, fasting total cholesterol, LDL, triglyceride values are to be done, and they are very much important. Obesity, body mass index more than 25 kg per meter square for Indian population is considered as obese. Waist circumference, men average waist circumference 102 centimeter, women to 88 centimeter. And according to WHO, who the person, the male who have more than 94 centimeter waist circumference and the female who has more than 80 centimeter waist circumference are at increased risk for development of the metabolic complications. That should be kept in mind. And this risk significantly increases when the waist circumference become much higher than 102 centimeter in men and 88 centimeter in women. And physical inactivity, tobacco use, excessive alcohol consumption. All of us know the unhealthy dietary and nutritional habit, family history. These are all the risk factors which precipitate the non-communicable diseases among the HIV population. So screening is most important to identify the early detection of the diseases and to prevent the comorbidities associated with these diseases and early management and to prevent the late complications and death. So for these reasons, the screening is very much important. Now, national technical guidelines are there. The overall aim is to early identification of NCD among PLHIV, thereby reducing the morbidity and mortality. As I have already mentioned this in my earlier slide, thus early screening, early diagnosis is needed to reduce the morbidity and mortality, to improve the quality of life and comprehensive management of HIV and NCD in under one umbrella in routine health program setting. So assessment, first of all, for the screening, assessment. Assessment shall be done at the time of registration of ART registration and at 6 months interval at ART center, and shall be repeated every 6 months through our monthly 6 monthly mandatory testing. We can monthly for at every visit at ART center, we can measure the blood pressure, we can calculate the BMI, waist circumference, and take the family history or history of hypertension, diabetes mellitus, and other factors associated with the risk factors for the NCD. And we can also do the through the mandatory test, we can identify the lipid profile, the urea creatinine level, the fasting blood sugar, the hemoglobin A1C, so that through this early screening criteria, we can assess whether the patient has a chance to develop NCD or not. And so screening and early detection, ART centers shall screen the PLHIV for diabetes, hypertension, cardiovascular disease, and common cancers also. It is very much important. And identify individuals who are at risk of developing NCD, warranting further investigation or action. Now, screening shall involve the simple history taking, whether the patient has family history, first degree relative have family history of diabetes, history of alcohol consumption, tobacco consumption, his dietary habits, his physical activity or inactivity, and calculation of BMI, blood pressure monitoring, blood sugar, random blood sugars testing, and hemoglobin A1C testing, all can be done at the ART center level. So routine screening and management of mental health portion is also very important. So when one should ask for, and there are specific questionnaire, I'll discuss this later, whether the patient is developing depression, suffering from psychological stress, and it should be provided for PLHIV in order to optimize the health outcomes and improve their adherence to ART. Now, first of all, the hypertension cleaning. There are guideline diagnosis management of hypertension, and there is 2023 guideline, which I will mention. All the PLHIV above the 18 years of age should undergo screening by healthcare provider through blood pressure measurement. When at registration into the HIV care or ART initiation, and every 6 months after ART initiation, or separately as a screening examination if requested by the patient or need filled by the healthcare provider based on the symptom. No, it should be done. I know that it is not practiced routinely at all ART center, but keep in mind that it can prevent you to develop the morbidity and mortality associated with this notorious hypertension. So we should always measure hypertension, blood pressure at ART center at the time of registration, and if possible at every visit. In case of already diagnosed patient and in normotensive patient, at least once in a 6 months. So there are basic criteria. So how to measure the blood pressure? All of us have digital machine. So patient should lie, patient should sit comfortably with the support, back support, and arms are relaxed. Relaxed arm, and blood pressure measuring instrument should be at the level of the heart, and patient must not talk during the measurement, and it is very important to use correct cuff size and positioning of the cuff. The line which goes to the digital machine should be on the brachial artery, and record in sitting position, don't round off, and the legs should be uncrossed and feet should be supported. Patient should feel relaxed. These are the basic criteria before measurement of the blood pressure, and use the correct cuff size, such as that the blood, what is the correct cuff size? That the bladder encircle 80 to 100% of the upper arm, and cuff bladder width should be at least 40% of the upper arm circumference. It should be keep in mind. And ensure cuff is on the bare arm or over thin layer of clothing. Avoid bunching of clothes or under cuff. So cuff size is very much important. 3/4 of the arm should be covered with the cuff, and the cuff breadth width should be at least 40% of the upper arm circumference. And this is the ideal positioning of the patient, ideal requirement of the blood pressure measurement instrument to measure the blood pressure of the patient. So a patient should avoid tea, and a few other criteria. A patient should avoid tea or coffee, exercise, tobacco use at least 30 minutes before measurement. Patient should have rested for at least 5 minutes before measurement. Ensures that he has emptied his bladder, and when taking the blood pressure, patient should be seated. I have already mentioned that back is supported, both feet resting on the ground, and should not speak while the blood pressure is being measured. Now, diagnosis of hypertension should be done by a physician or staff nurse using the validated device following the standardized BP measurement procedure. And it should be based on the at least 2 measurements taken at least last 2 visits, which are at least 1 to 4 weeks apart. So if the systolic blood pressure is more than 140 and diastolic blood pressure is more than 190, patient is hypertensive. And if it is between systolic blood pressure is between 140 to 159, grade 1 hypertension, 59 to 80, grade 2 hypertension, more than 180 millimeter of mercury, grade 3 hypertension. Likewise, similarly, diastolic blood pressure 90 up to 90, it is normotensive, 90 to 100, grade 1, 100 to 110, grade 2, 110 to 120, grade 3 hypertension. Now, the fasting blood sugar. So, first of all, we should measure the blood pressure. Then, the second thing, blood sugar. Fasting blood sugar measurement can be done at the baseline and at 6 mandatory with the mandatory test at 6 months interval. And now another thing is urine analysis. If the patient has proteinuria is the early indication for the diabetic nephropathy. And one should remember that proteinuria is early indication of tenofovir toxicity also. And it is a marker of higher risk of cerebrovascular mortality and morbidity. Desirable blood pressure in patient is 160. If the patient has proteinuria or if the patient has CKD, it should be 120 by 80 millimeter of mercury. The desirable for the PLHIV with systolic blood pressure 160 millimeter of mercury and 100 millimeter of mercury, it should be measured. Ideally, it should be between 140 to 90. And if there is CKD, it should be 120 to 80 millimeter of mercury. Lipid profile should be measured, and dyslipidemia is an increase, is a cardiovascular risk factor. Serum creatinine, electrolytes, sodium, potassium, assessment of renal function, ECG, and if necessary, echocardiography should be done if you suspect a patient having hypertension. Now that I have already mentioned target of the BP control for the patient below 80 years of age, systolic blood pressure is 140 millimeter of mercury, diastolic is less than 90 millimeter of mercury. Patient 80 years or older, 150 millimeter of systolic with less than 90 millimeter of diastolic. All the patients require lifelong lifestyle modification, including dietary changes to heart healthy diet, salt limited to 5 to 6 gram per day, low fat diet, regular exercise, weight maintenance with target BMI 18 to 22.9 kg per meter square. Obese, when we call obese, 25 kg per meter square. And so smoking, alcohol must be prohibited. So management of hypertension in adult. Antihypertensive drug therapy along with the lifestyle modification, low salt intake, exercise, control of blood sugar, control of CKD. There are several drugs to monitor the hypertension. Angiotensin converting enzyme inhibitors like enalapril, angiotensin receptor blocker, ARB like losartan, telmisartan, calcium channel blocker like amlodipine, cilnidipine, thiazide diuretic like chlor hydrochlorothiazide, chlorothiazide, beta blocker like atenolol are there. So if there is grade 1 hypertension, that is 140 to 159 millimeter of mercury systolic blood pressure and 90 to 99 millimeter of mercury diastolic blood pressure, you just recommend the lifestyle modification for first 3 months. And then if there is grade 2 hypertension, that is 160 to 179 millimeter of mercury systolic blood pressure along with 100 to 109 millimeter of mercury diastolic blood pressure, you should add one drug along with lifestyle modification. But if there is grade 3 hypertension, that is more than 180 millimeter of mercury systolic blood pressure with diastolic blood pressure more than 110 millimeter of mercury, at least 2 drug pharmacotherapy with the lifestyle modification is recommended. Now, the screening, diagnosis, and initial management of hypertension is adult. So care provision and referral system should be there. Screening, diagnosis, and treatment of uncomplicated hypertension can be provided by a trained medical officer at the level of the ART center. If there is grade 3 hypertension or heart failure or the failure to achieve the treatment goal following initiation of dose, increase the two antihypertensive to a maximum level and refer to the expert. And if what is resistant hypertension? If the blood pressure is uncontrolled, remains uncontrolled in spite of 3 antihypertensive drugs with its full dose, then it is called resistant hypertension, and you should always refer the patient to the medical expert. So immediate referral to the appropriate facility and proper provider should be done whenever anybody feel are capable to control the blood pressure. Now, second thing is important, diabetes mellitus screening, diagnosis and initial management of diabetes mellitus. We'll talk about the recent guideline. So, blood pressure, similarly, like hypertension, blood sugar should be monitored at the baseline, and thereafter every 1 to 2 months who are already diabetic, or as a mandatory test who is normoglycemic. But the close monitoring is needed if the patient is already diagnosed of having diabetes. So what are the complaints related to diabetes? The symptoms of diabetes are, all of us know that polyuria, polydipsia, and weight loss, in spite of polyphagia. The other symptoms are tiredness, weakness, generalized pruritus, recurrent urogenital infection. One should keep in mind that undiagnosed diabetes, if there is generalized pruritus, recurrent urogenital infection, delayed wound healing. And what are the diagnostic criteria for diabetes? If there is symptom, then do a random blood sugar. If random blood sugar is more than 200 milligram per deciliter, the patient is diabetic. If the fasting blood sugar level is more than 126 milligram per deciliter, we can stamp as diabetic, along with 2-hour postprandial glucose test more than 200 milligram per deciliter. And if glycated hemoglobin level is more than 6.4%, the one should consider as diabetic. And if it is between 5.5 to 6.4, it is pre-diabetic. And diabetes diagnosed using any of these criteria should be confirmed with another test subsequently. So prepare your supplies and wash your hand items needed, that is glucometer, test strip, lancing device. Turn on the glucometer, insert the strip at the end of the glucometer. Now place the landing device on the side of the finger tip and prick the finger. Then gently squeeze the finger to get a drop of blood onto the test strip. And now wait for the meter to give the recording. This is the way how one can measure the blood sugar, sorry. Random blood sugar. Blood glucose measured at any time of the day without regard to time since the last meal. And what should be the value? It is 200 milligram percent. It is easier to perform and less sensitive than the other tests. However, for the purpose of the screening, random blood sugar over 140 milligram per deciliter taken as the requiring further follow-up. I have already mentioned that if the fasting blood sugar is more than 26 milligram per deciliter and postprandial blood sugar is more than 200 milligram per deciliter, one can be stamped as diabetic. Previously, non-diagnosed patient with RBS 140 milligram per deciliter must be referred to the medicine department for fasting and the previous level to make the conclusive diagnosis. Additionally, if the patient's hemoglobin A1C concentration is more than 6.5, better to mention as 6.4, it will be diagnosed of having type 2 diabetes mellitus. Now, how we will monitor the diabetes patient? So, blood glucose. FBS and 2-hour postprandial blood glucose at least once in a month or more often if the values are not in the ideal target range. It should be done. Hemoglobin A1C level at least every 6 to 12 months if available, and more often every 3 months if the values are not within the target range. Clinical examination along with these test results should be done during every visit, minimum at every 3 months. Now, the screening for long-term complication of diabetes. What are the long-term complications of diabetes? Retinopathy, nephropathy, neuropathy, peripheral vascular disease, and Most importantly, coronary artery disease at least should be done once in a month, more often if needed. Basically, baseline, if the patient is diabetic, his every system should be checked up for the first time, and if the coronary artery disease and retinopathy should be monitored frequently. Optimizing weight, waist circumference, and the blood pressure and lipids are all needed, along with the tight control of the blood sugar. Routine examination of the food should be done during every visit, and education regarding the food care to be given to the patient at every visit, and discourage about the tobacco and the alcohol usage to the patient. Additional investigation for a diabetic, lipid profile, serum creatinine, and urine analysis for proteinuria. All the time you should keep in mind that this is very much needed. Now, diabetes mellitus, care provision and referral, screening. First of all, we'll screen the patient. Then we'll diagnose the patient. If the patients, I have already mentioned the diagnostic criteria to detect as the diabetic one. Now the management, the lifestyle modification and dietary habit changes and exercise and stoppage of tobacco and alcohol is recommended for all diseases, not only in case of hypertension and diabetes, but also for prevention of cancer also. Now, initiation of oral hypoglycemic agent shall be done by the physician, and continuation of treatment can be provided by a trained medical officer in PLHIV and with the controlled diabetes. Management and the follow-up by the physician are recommended in patient with uncontrolled hyperglycemia, regardless of metformin and other sulfonylurea use. Now, the cardiovascular risk factor screening, assessment, and management of in PLHIV. So I have already mentioned twice or thrice that cardiovascular disease risk factors are hypertension, diabetes mellitus, dyslipidemia, obesity, that is BMI more than 30 kg per meter square, increased waist circumference, men 102, female 88 centimeter, physical inactivity, tobacco use, excessive alcohol consumption, unhealthy dietary and nutritional habit, and family history of hypertension and diabetes. Now, anthropometric measurement. These are very much important. Body mass index. Body mass index is used as a screening tool for estimating the total body fat content in a person's body. It is calculated by dividing a person's weight in kg by his or her height in meter square. That is kg by meter square. Now, how we will categorize? If it is in between 18.5 to 22.9 kg per meter square, we will consider it as normal. If it is less than 18.5 meter square, then it is underweight. It is between the 23 to 24.9 kg per meter square, it is overweight. And more than 25 BMI, it is obese. Central obesity, what do you mean by central obesity? Waist circumference more than 90 centimeter or higher in men and 80 centimeter or higher in female is considered as central obesity. Now, another important factor is mental health. The HIV people are very much prone to develop psychological ailment due to some social stigmata, social strata, and also his personal ailment. That is the HIV per se, as well as opinions and experiences regarding the HIV in their surroundings. And they faces multiple type of psychological issues like depression, which is very common, anxiety, and internalized stigmata, etc. Any such issue can significantly hamper adherence and mental well-being. Depression in the first 2 to 3 times are more prevalent in PLHIV than in general population. So all PLHIV should receive basic screening for depression before initiation of ART and thereafter every 6 months using the following questions. At least 2 questions you can ask. that during the past 2 weeks, have you ever been bothered by feeling down or depressed or hopeless? During the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? These are the very two basic questions you can ask at every visit whenever the patient comes to you to identify as a screening tool for identification of depression. So there are patient health questionnaire, 9 questionnaires are there. All of these questionnaires are very important, and there are several scoring systems, 0, 1, 2, 3, and that is 0 not at all, several days if the problem is retained for several days, or whether it is more than half a day or nearly every day. So if anybody shows little interest or pleasure in doing things, questionnaire 1. If anybody feeling down, depressed or hopelessness, question number 2. Question number 3, if there is trouble falling or staying asleep or sleeping too much. Question number 4, feeling tired or having little energy. And if the patient develop poor appetite or sometimes they overeat. Question number 6, feeling bad about yourself or you are a failure, have let yourself or your family down. These are the thinking. If one develop, it should give you a alarming signal. And is question number 7, travel concentrating on things such as reading the newspaper or watching television. Question number 8, moving or speaking so slowly that the other people could have noticed, or the opposite being so fidgety or restless that you have been moving around a lot more than the usual. And question number 9, if there is thinking of self-harm, suicide, or anything, sometimes this type of attempts should always arise a question. So if there is total score is 27, if there is 0 to 4, depression is unlikely, 5 to 9 score, mild depression, 10 to 14 score, moderate depression, 15 to 19 score, moderate to severe depression, and 20 to 27 score is severe depression. And if there is moderate depression, always need psychological counseling through trained counselor. If moderate to severe depression or severe depression, they always ask whether the patient is on efavirenz therapy or not. Substitute efavirenz with the other antiretroviral drugs and always refer to a psychiatrist for further assessment and evaluation of depression. And this mental health problem should always keep in mind which can save the life of the patient. And what are the components? Psychosocial component, self-assessment skill, and reduction of stress. Psychosocial component, explain about depression and assure that it can be managed. That can be done. This type of counseling can be done at the ERT center level. And feeling of hopelessness, worthlessness, negative emotions are part of depression and will revert with proper counseling and treatment. And inform on course of counseling and treatment, identify supportive family members and involve them as appropriate, and involve peer and community support group. These are very much important whenever you think that the patient is suffering from depression, through screening, through diagnosis, through different scoring system. Self-management skill, you should always ask that continue ART as prescribed, identify the activities that they have used to find interesting and pleasurable, encourage participation in these activities, get regular or sufficient sleep. Approximately one need 7 to 8 hours of approximate sleep. Physical activities to be increased. Contact ART center or healthcare facility immediately if thoughts of self-harm. And how will you reduce your stress? Identify and try to reduce the stress point. Identify and discuss stress increasing points such as health issues, families, relationship problem, gender-based or partner violence, finances, stigmata, discrimination. Identify, discuss problem-solving techniques. So, medical management of depression. Depression can be managed by a combination of medical and psychological interventions. Whenever needed, antidepressant should be prescribed by a psychiatrist. Antidepressant treatment is generally given 6 to 9 months, and a dose should start with a minimum recommended dose and increase gradually. It takes 2 to 4 weeks for maximum therapeutic benefit and improvement if symptoms to be achieved. And antidepressant should not stop abruptly. Dose should be tapered gradually. And the two major classes of antidepressant, that is amitriptyline and SSRI group of antidepressants are there. So mental health disorder during childhood and adolescence are defined as delays or disruption in developing age appropriate thinking, behavior, social skill, or regulation of emotions. Prevalence of mental health condition in children and adolescent is between 6 to 12%. Prevalence of 7.3% in children and adolescent aged 13 to 17 years. Overall, 8 to 13% of children are estimated to need of mental health services. So warning signs: persistent sadness, withdrawing from or avoiding social interaction, hurting oneself or talking about the hurting oneself, talking about death or suicide, outburst or extreme irritability, out of control behavior that can be harmful. Number 7, drastic change in the mood, behavior, or personality. If one develops changes in the eating habit, changes in the difficulty in sleeping, if there is loss of weight, frequent headache or stomachache, difficulty in concentration, and changes in the academic performance, avoidance or missing from school, then referral should be done. And mental health disorders should be referred to undergo through screening for mental health condition. For ART center at district level, PLHIV should be referred to National Mental Health Program, and ART center level to the Department of Psychiatry. And recording and reporting are always important as a part of the documentation. Documentation of screening and referral should be documented in white card and the patient follow-up section 13 and the investigation section. Details regarding the comorbid condition should be documented in section 9 of the white card, and these details should also be captured in the IMS. So strategies of prevention of mental health in NCD and in PLHIV: health promotion, screening of early detection, and referral and diagnosis and management. Now the health promotion through physical activities, to weight control, diet, tobacco cessation, avoidance of alcohol, adherence to treatment, these are important. So what is the role of nurse? To assist the MO during the physical examination of the patient, to assist in follow-up care, BP screening during the blood pressure, using blood pressure apparatus, record the height, weight, hip circumference, waist circumference, record the result of lab investigations in the survey form, and to explain the patient and the family the risk factors of the NCD and promote the healthy lifestyle. Screening of the mental health, basic screening for depression, asking 2 questions: whether you have feeling depressed or loss of any pleasure in last through 2 weeks. Any patient who answers yes of these 2 questions, either of these 2 questions shall be screened further for the depression through PHQ-9, and ask for personal or family history and the risk behavior. Questions will assess core symptoms and depression, to provide counseling on diet and lifestyle management, and to assist in follow-up care and referral. All these points are important for a nurse. And what is the role of medical officer? He will take the complete history, including the tobacco smoking and the alcohol consumption, and also do the physical examination, clinical examination, and review the signs and symptoms, prescribed appropriate laboratory investigations, confirmation recording of the findings, and if the BP or RBS is high, start preliminary treatment, record the findings and the white card, and make appropriate referral. And management of NCD at ART center level, ART MO, SMO can start treatment for NCD at the ART center itself. For diabetes mellitus, start metformin, add glimepiride or other sulfonylurea depending on the availability. For hypertension, start amlodipine or ramipril or telmisartan depending on the institutional availability, or else refer, if there is other help needed, refer to the medicine department of the same institution or the NCD clinic nearby dispensary or the district hospital, and follow up if the patient has reached to the referral center, and review of the prescribed formulation is needed by the medical officer. Now, there are few challenges. Some investigators may not be available. Some investigations may not be available, and the PLHIV may need to visit the higher center, and people may have to visit another facility for the management of NCD. So it may be a district hospital or medical college. So comprehensive management cannot be given to in that case. In that case, patient may miss or follow up the appropriate date to the ART center. Pattern of the prescription of the drugs varies from state to state depending on the EDL, and complications may need specialist management. So at conclusion, non-communicable diseases are common among APL-HIV, and they are leading cause of morbidity, mortality in this decade in PLHIV. With the aging population of PLHIV, NCDs are going to play a dominant role in the management of the PLHIV, and screening for NCD is simple, and measuring BP, RBS, BMI, lipids, but it should be done at every level by the nurses, by the medical officers, by the specialist MO. An initial management of NCD is possible within ART center. And finally, the integration of NCD and HIV care is critical to achieve the holistic approach to PLHIV. And with this, I am concluding this session on the non-communicable diseases. Thank you for your patience. Thank you.
Thank you so much, ma'am. Any questions from the participants? Please feel free to unmute your mic, or you can even type in the chat box.
Thank you, ma'am.
Thank you.
Anybody would like to ask any questions regarding NCDs? Ma'am, I don't think there are any questions. Thank you so much for facilitating this session. Thank you to all the participants for patient listening. Ma'am, can we conclude the session now?
Yes, ma'am.
Yes, thank you. Thank you so much, Ismail sir. Thank you for all your support. Kiran sir, we can stop the recording.
Our patient.